Very good morning, everyone. And thank you, Dr. Hazra, sir, for having me here and giving me this opportunity. And thank you, panelists. I think I'm going to talk today on this tower in bicuspid aortic valve. Where are we today and what we know till now? I think this topic is really very relevant for India as well as the Asian continent, where the bicuspid aortic valve incidence is extremely high. In India, it is as high as 40 to 45%. What we know about bicuspid aortic valves? There are conflicting reports of efficacy, no randomized data till now, still some uncertainty with procedural conduct, and little hesitation about treating high and intermediate risk of bicuspid patients. Surgery, well, it still have a role in some patients, in very young patient or patients who are requiring Rose or mechanical valve, patient with significant aortopathy, hostile LVOT calcium and anatomy, and unicuspid aortic valves. The concerns with bicuspid aortic valve, the annulus is extremely large, eccentric, elliptical. The sealing zone is whether it is annular or it is supraannular. Positioning, whether you have to place them at the annulus level or supraannular level, whether they will anchor, they will not anchor. Severity of bicuspid aortic valve depending on whether it is a type 0 or type 1 with calcified raphe, without calcified raphe. Asymmetric aortic cusp, non-circular deployment. Coronary occlusion in spite of coronary heights are good. Heavily calcified leaflet, they are extremely heavily calcified valves. Calcification with left ventricular outflow tract and aortopathy. This is very important. The people who are treating towers and aortic stenosis, they should know this classification very well because that will help you to select your patients. Type 0, which is no raphe. Type 1, which is 1 raphe. Type 2, it is 2 raphe. It has been subclassified again in type 1 is subclassified again into 3 types, type 1A, 1B, 1C, 1A being the commonest, in which the left and R cusp is fused. Anatomical consideration, if you see, it is a heterogeneous cusp, sinus morphology, heavily asymmetric calcification, long commissural distance, aortopathy, angulation, and coarctation association. But we have to remember one thing, bicuspid aortic valve has been excluded from all the RCTs, whether it is a surgical aortic valve replacement trials or whether it is a transcatheter aortic valve replacement trials. So this is very important. There is no randomized control trial in bicuspid aortic valve till date. Sizing is little different from tricuspid, but almost in 80 to 88% of the times, the sizing is on the basis of annular. Because most of the times it is either tubular anatomy or a flare anatomy. Only the anatomy where it is tapered, the sizing can be done with the supraannular measurement. Otherwise, almost 90% of the times, the sizing is based on annulus. There are not only the sizing and selecting a valve, you should always try to do and analyze the bicuspid aortic valve with the circle method, in which you can, whatever the valve we are trying to use, you can use it into the trementio and see how that valve size is going to behave with the whole aortic root complex. That will give you an idea and that will prevent and major complication like annulus rupture or coronary occlusions. What evidence says? In 2016, there is a study which has been published comparing 546 patients compared to tricuspid aortic valve. And what it shows, aortic root injury, aortic rupture, second valve implantation, paravalvular leak, and new pacemaker were significantly higher in bicuspid aortic valve towers compared to tricuspid aortic valves. Even the success rate with the earlier generation is significantly lower. It is 78% compared to the tricuspid aortic valve. Even with the latest generation and the new generation devices, the aortic root injury, second valve implantation, and paravalvular leak has gone down, but still it is numerically high. The 1-year mortality in this comparative analysis shows it is similar, 11.4 and 11.2% between bicuspid and tricuspid aortic valve. But is it true? Have they considered all the bicuspid, or they were selective in selecting their bicuspid data? Even STS registry, TVT registry shows the conversion to open heart surgery, annulus rupture, second valve requirement, and even all stroke and pacemaker were significantly higher in bicuspid aortic valve towers compared to tricuspid aortic valve towers. And the limitation for this registry, the bicuspid aortic represents a heterogeneous anatomic cohort, and it is possible that the operator has selected the most favorable anatomies, not all anatomies. So it is a biased. So does bicuspid aortic valve morphology plays a role in TAVR outcome? Yes, let's see about it. There's a beautiful study which has been done by Dr. Yoon and Makkar in US, which they classified the bicuspid aortic valve depending on raphe, calcified raphe, non-calcified raphe, and the leaflet calcification. And they compared the outcome in this patient with previous earlier generation and the latest generation devices. They classified it calcified raphe, non-calcified raphe, or no raphe, and combination with excess leaflet calcium, whether mild leaflet calcium or excess leaflet calcium. And what they found, the all-cause mortality is 15% at 2 years in this subgroup. The all-cause death, according to RAFE, the patient, bicuspid aortic valve patient with calcified RAFE, the 2-year mortality is 20%. So it is significantly and it is very high compared to the patient who are having non-calcified RAFE or no RAFE. The all-cause mortality, according to the leaflet calcification, is at 2 years is 20%. So this is extremely high. So calcified RAFE and excessive leaflet calcium are independently correlating factor for all-cause mortality with bicuspid aortic valve TAVRs. They studied it more detail, and what they found, if those patients who are having calcified RAFE plus excessive leaflet calcium, that subgroup, the 2-year mortality is 25%. It is very high. Even after a successful TAVR, the 2-year mortality in a patient with calcified RAFE with excess leaflet calcium is 25%. What does that mean? Every out of 4 TAVRs, one patient is not going to make it at the end of 2 years. So is it right? Even if you see the procedural and 30-day outcome according to the bicuspid aortic valve phenotype, the phenotype with excessive calcified RAFE and excessive leaflet calcium has significant PVL, aortic root injury, major vascular complication, and 30-day mortality was significantly higher in this group compared to a patient who are having either calcified RAFE or calcium excessive leaflet or none of the above. Even if you see with all-cause mortality, even with the latest devices available in the market as of today, the phenotype with excess leaflet calcium and calcified RAFE, the 2-year mortality is as high as 23%, nearly 23%. So what are we offering to our patient? Bicuspid aortic valve are really young patients. And this kind of subgroups, even if they are low risk, as Anup has rightly pointed it out, still there is a scope for surgical aortic valve replacement, remove those calcified leaflet and take them out and put a new valve with a root enlargement. If you see the outcome in this subgroup, even with the latest device, the paravalvular leak, aortic root injury, major vascular complication, and 30-day mortality, even with the latest device, is extremely high with a subgroup with calcified RAFE and excess leaflet calcium. So this is the anatomy and this is the phenotype which is really not suitable for TAVR as of today. The all-cause mortality and aortopathy has some slight significance. The aortopathy, the all-cause mortality at 2 years is 18%. So what are the learning points, what we learned out of it? The calcified RAFE and excess leaflet calcium were independently associated with increased procedural complication and 2-year all-cause mortality. The high-risk bicuspid aortic valve phenotype, that is the patient who are heavily calcified RAFE and excess leaflet calcium, was found in 26% of the anatomies, and they are associated with 3-fold high mortality. So I still feel this is the subgroup which is still not suitable for TAVR. These are the subgroup where we should excise those leaflet, put a valve, surgical valve, and offer them and further future option of treatment. The impact of bicuspid aortic valve morphology on outcome was consistent in low surgical risk patient as well as the patient who undergo an TAVR with the latest generation devices. What is the clinical implication? The CT assessment of morphology in bicuspid aortic valve stenosis helps in assessment of anatomical risk for TAVR. And in the absence of randomized control data as of today, the approach to bicuspid aortic valve patients will be should be on a CT-based anatomical assessment to identify which are the favorable anatomies for TAVR and which are non-favorable anatomies for TAVR, and then we subject this patient for SAVR or TAVR. In order to conclude my talk, Not every bicuspid aortic valve is suitable for TAVR. I would like to highlight this very categorically. In India and in Asian subcontinent, the bicuspid aortic valve incidence is as high as 40 to 45%. And we treat this, the dedicated bicuspid aortic valve randomized control trial is a need for time. Thank you for your patient hearing.